All right, I think we'll get started. Thank everybody for coming today. The LA-CaTS Center is proud of Louisiana's scientific response to the COVID-19 pandemic. Researchers from around the state are working on the front lines, conducting research to improve testing, surveillance, health impacts, and treatment. As a resource to all scientists, clinicians, and citizens, we have been hosting the Louisiana COVID-19 Chronicle seminar series in this virtual format. Since October 2020, the LA-CaTS Center has been featuring scientists and clinicians showcasing their work being done right here in Louisiana in the battle against COVID-19. We want to congratulate the researchers who have been contributing to our knowledge on COVID-19 and hope you will join us for future episodes of the LA-CaTS Center Louisiana COVID-19 Chronicle Seminar Series. I will note that this will be the last one for now. We'll break for the summer and we'll get started in either late September or early October. During the talks, please type your questions in the chat window. We'll save time at the end of each to share your questions with each speaker. Also, we invite everyone to remain on the webinar after the presentation for open discussion and an opportunity to network with fellow attendees. And again, this will be the last session until fall. So I'd like to first introduce Dr. Vanchiere. Dr. Vanchiere is a pediatric infectious disease specialist in Shreveport, Louisiana. He received his medical degree from Emory University School of Medicine, has been in practice for more than 20 years. Chief of the LSU-Shreveport Department of Pediatric Infectious Disease Section, Dr. Vanchiere earned his doctorate from the Emory University before completing both residency and fellowship training at Baylor College of Medicine, Houston. And Dr. Vanchiere is also the past president of the Louisiana chapter of the American Academy of Pediatrics. So today he will present on COVID-19 testing and vaccination in schools, what we can expect for 2021-2022. Dr. Vanchiere, share your screen.
That and go to that and share F5. Oops. All right, does that look good? Great. All right, it's a pleasure to be with you guys. I think a little detour from the typical format for this series that I won't be really speaking much on research today, but really an update on what we can expect in the preparations this summer for the 21-22 school year. And of course, a lot of opportunities for research. One of the big things happening right now is dealing with vaccine concerns. So I thought I would spend just a few minutes touching on that. This is one of those areas where everybody is looking for the right analogy, the right connection to use in the right situation. And I think there have a few insights there that may be helpful. Then we'll focus on back to school and vaccinations and testing, and touch a little bit on other sort of hot topics in pediatric, the MIS-C syndrome of inflammatory syndrome post-COVID, and also, as many of you have seen, the myocarditis, pericarditis associated now with the mRNA vaccines. And we'll touch a little bit on that in preparation for the ACIP meeting tomorrow to discuss that in particular. So in dealing with vaccine concerns, I saw a very good talk recently by Brian Castrucci from the de Beaumont Foundation. Their website is Changing the COVID Conversation. And some of the things he pointed out that are very helpful in dealing with vaccine concerns, and he's starting to use, and others are too, use vaccine concern as our sort of label rather than vaccine hesitancy, which has a little more negative perspective. And it's always about nuance and words. But the 4 points here I think are real important: to stick to the facts and don't be afraid to acknowledge the rationality and reality of people's concerns. That you know, for a lot of people, what they've heard for a very long time is, oh, it takes a decade to make a vaccine at least, and then all of a sudden, boom, we've got multiple vaccines within a year. And calling that process Operation Warp Speed was not necessarily maybe the best name for it. So it's okay to acknowledge that concerns about the vaccines are rational and really stick to the facts. And things like 96% of all doctors have received the vaccines to date, and as one reference, we know physicians are one of the most trusted sources of information. Where we're going to get through the next phase of vaccinations is in the physician's offices. These apolitical and trusted messengers are really the key, starting with physicians and other providers, but it includes pharmacists, pastors, and peers, and encourage the people you have vaccinated or whom you know have been vaccinated to talk to other folks about their experience with vaccine. Importantly, we shouldn't be blaming and shaming. And, you know, some of us choose to wear masks when we go to the grocery store or church, even though we're vaccinated, and that's okay. And others are less worried, less concerned, and may not wear masks. And even the even less concerned are those who are not vaccinated, perhaps, and not wearing masks. And so there's a whole spectrum here in the population. And I've tried to emphasize that risk will never be zero. Regardless of where we are in that spectrum, risk will never be zero. And each of us will have to find our own comfort zone with where we are in our own risk spectrum, and how we mitigate that risk and perceived risk is going to be an individual decision. And finally, you know, we got to keep it about health, not politics. Make our messages simple, relatable, and relevant to people. And that's, I think, very clear that this is about health. It shouldn't be about politics. And one of the big messages that Dr. Castrucci pointed out is that, you know, in a debate, there's always a loser. So don't make it a debate. Make it about an educational opportunity to share your message, acknowledge people's concerns, and recognize and acknowledge to them that each person has their own choice to make with regard to vaccines. And this list, I'm not going to belabor, but really is helpful to see words that are going to be more effective in your discussion. We're not trying to dupe people. We're not trying to hide things from people, but really we can focus more on the words on the left there under the green column of better words to use that help and are more collaborative and educational as opposed to divisive. Even just talking about the work of researchers and scientists in making this vaccine or all these vaccines, as opposed to talking about pharmaceutical companies, which tends to raise people's eyebrows and make them more concerned about financial incentives and the like. So a good spectrum of words there on the left to consider using. Many of you are familiar with this model. It's sort of a business model of how innovation gets adopted in the community and in our society, and it can apply to lots of things. And it highlights that there are some people to the left of this curve that are, you know, innovators. They get the first device as soon as it's ready, nifty as it is, and the early adopters want to be pushing the envelope, and the rest of us come along a little bit later. The same is true with our vaccines, and we've started talking about community immunity, and that takes time. And what we've seen in our experience with our teams administering now over 72,000 doses of vaccines is that early on we had a very highly motivated group of people. Older folks in the population who are very scared about COVID, have high rates of mortality and have a right to be scared about COVID, but were very highly motivated. And so they were looking for vaccines in any place they could find them as quickly as they could. And they drove hours sometimes to get vaccines and didn't mind waiting in line. And then the next phase, you know, are folks who are motivated and couldn't wait to get the vaccine. These are the people who are in their 40s and 50s who didn't quite qualify or didn't qualify early on in the availability of vaccines, but just couldn't wait to get vaccinated. So they went, some of them went every day to vaccine sites just in case there was an extra dose so it wouldn't be wasted and that kind of thing. And we're now approaching this, you know, midpoint of the curve. We're probably hopefully a little over the 50% point nationwide, but in Louisiana, we're still really in this early majority phase. We're not even convincingly to 40%. as a state, but in some areas and some demographics, we're way over that, in our elderly population in particular. And so we've got to begin to look at vaccination data in a more granular fashion and understand where we're making good inroads and where is vaccination uptake high and where is there more vaccine concern. The next group is going to be the not quite sure yet and maybe too busy. These are folks who've been working, who work 9-to-5 jobs and can't take off to go get the vaccine, but they're willing. And so that's really where we are now. What I call phase 2 of our delivery is not mass vaccination, but mobile vaccination. And our teams are going out 4 and 5 different teams a day into different areas of our public health region to deliver vaccine in community centers, at civic events, at fairs and festivals and the like, to really bring vaccines to where people are. And included with that is our schools in our area. We have been fairly successful with the end of in the last month of the school year, getting vaccines out into the high schools and into some of the middle schools. And we're continuing to use those schools as a community focus point where people can come and get vaccines on a regular basis. And then, the last group will be the not for me. And as I said before, this decisions are going to be individual. And my point here is that after this late majority, and probably a good bit of this late majority and what are called the laggards here, this is a group that is not going to get vaccinated in any format that is publicly sponsored. They may get vaccinated when their physician makes a personal recommendation to them to get vaccinated. And so really phase 1 was mass vaccination, phase 2 is mobile vaccination, but phase 3 really to get the last third to half of our population vaccinated is going to happen in physicians' offices in that one-to-one discussion with a trusted voice. Here's the breakdown of the data as we get into more of the pediatric discussion of COVID-related deaths. And you can see that the COVID-related deaths since January 1st of 2020 number not quite 400 in the pediatric population. And that's comparable, a little more like twice as many as the influenza deaths in the prior influenza season, 2019-2020. If you hadn't heard yet, the influenza deaths in the 2021 flu season numbered exactly 1 confirmed death by CDC, which is phenomenal because we just didn't see any flu. But the point here is that, we all recognize that death as an outcome related to COVID in the pediatric population is very, very unusual. And this is rare, right? And as you get into the older populations shown here, risk of death in those age brackets and cohorts goes up dramatically. So that in folks, over 65 years of age, we're talking about, 100 to 150-fold risk higher than that of young adults in that 19 to 44 years category. And over 75, it's even higher than that. So for the pediatric population, they have largely been spared. But again, we are talking about twice as many deaths, at least, as we see in a typical flu year. And over the past decade, influenza deaths average around 100 to 120, sometimes 150 or more per year in the pediatric population related to flu. So COVID is definitely taking its toll on kids as well. Interestingly, when you look at the breakdown of those pediatric deaths due to COVID, this graphic shows you the number of deaths in 0 to 4 age range, 140, in the 5 to 15-year-old age range, Hispanic and Latino, you're talking about almost 100. So Hispanic and Latino children have been disproportionately affected, white children following, and then non-Hispanic Blacks in sort of the third in that group in terms of likelihood of death. So the disproportionate effect on Hispanic and Latino, we think, is largely related to access to care in many parts of the country, and also hesitancy about and lack of relationship long-term with physicians. So what do we know about transmission of SARS in our schools? We have in Louisiana been very successful in the past year, keeping transmission in schools to a very minimum. And we have not had in our region of the state any school focused or school related outbreaks. And what CDC has said is summarized here in these 4 points, that COVID transmission in schools is really an indicator of community transmission. As transmission spreads within schools, we know we can limit that with the strict mitigation measures that have been put in place, and we have already done that in Louisiana. It's a really sad state of affairs for many parts of the country, especially in large school districts in Chicago and New York and Los Angeles, where kids have been out of school for an entire year and missed that year of education. And that's a big setback in those areas. We've been quite lucky here in Louisiana to be able to implement the strategies and be successful with learning. Not as good as we always could. Hybrid learning is not as good as in person. And those who only did remote learning, many of them suffered dramatically in this, in terms of their academic achievement and also their mental health. So there are a lot of factors here, but schools are not the source of outbreaks of COVID. And that's a real important bottom line. When community rates are high, of course, there's an increased likelihood of COVID in schools and potentially transmitted in the school setting. But evidence is very, very clear to date that when schools implement good preventative mitigation strategies, that transmission in the schools can be very limited. So what are we going to do come fall? And here is the release from HHS press office of March 17th. So just 3 months ago, the Biden administration put forth the investment of $12 billion to expand COVID-19 testing across the country. And this is a big push. You can see in the subheading there, $10 billion for school screenings to help with reopenings. And that's providing reassurance in those areas that haven't been able to open. The proportion of that funds coming to Louisiana is really good. $140 million for school-based testing for the next 15 to 18 months. So we're talking about significant amount of money available to the state, and the Department of Health and the Department of Education are working to implement a testing strategy for schools. So what's that going to look like? The testing plan for K through 12 for the coming school year. It's a collaborative effort, 15 to 18 months, depending on when the money runs out, but an aggressive plan to really optimize testing in advance of vaccination rollout, especially for younger kids. Contracts are currently under negotiation between LDH and contractors who can meet the qualifications for the testing program. That includes labs, but it also includes the collection of specimens and other techniques that I'll review with you. The expectations that the state has built or sort of based their budgeting on is the expectation that, number one, about 20% of schools will elect to participate in a testing program, that they can opt in. They're not required to do any testing. It's an opt-in program for the schools, and hopefully 20% or more will participate. The state has put together both a DIY or do-it-yourself opportunity. So a school can say, we'd like to use our school nurses to do a testing program in our school and contract with a lab ourselves or a local lab to actually do the tests. And we want to take that DIY approach. The other option is really a contract or a turnkey option, where an outside company would work directly with a school or a school system and come in with nurses or appropriate staff to do swabbing, take those specimens, get them to the lab, and get results reported back to parents and schools on a timely basis. Where that falls, some schools will likely take the DIY option, but it's expected that many will go for the turnkey option because school nurses are an underfunded situation, and they have been forever. And so the likelihood that a school is going to take on the bandwidth and has the bandwidth to really implement a good testing program, I think, is fairly low. Each school will have a state-funded COVID-19 testing liaison. that will work either with contractors or with the state to have their program set up. Students and parents also have an opt-in approach. So no students can be required to participate. It's an opt-in only, and the hope is that 15 to 20% of students per school will participate in the program. And the state has built in, using that $140 million budget, incentives primarily based on cash for kids to participate in the program. And the expectation is that this is weekly testing. This is broad-based surveillance in the schools, really utilizing the school as that sort of indicator of community activity, as it were, by doing frequent testing of a cohort of canaries in the coal mine or sentinel population kind of thing. Weekly testing, it can use oral swabs if available and if validated. That's been a really tough one. In our lab, we have not had success really demonstrating that oral swabs are nearly as sensitive as the nasal swab. Even mostly we use mid-turbinate nasal swabs, and we've done over 340,000 swabs in primarily our nursing home population, and mid-turbinate is our standard. But we would like to validate oral, but in our head-to-head tests, the difference in detectable virus in people who are confirmed positive and symptomatic with COVID is about 3 logs difference, and about 10 to 12 CT values on the PCR testing. And when you move that into a pooling paradigm at up to 1 to 5 pooling of those swabs or specimens from different kids, the loss of sensitivity with oral swabs is a setup for a waste of money, a waste of resources, really. And finally, the state is requiring that we have results available next day, not within 24 hours, but at least next day, via portals for parents and schools to access. LDH then would handle any contact tracing that needs to be done. Schools would be empowered, as they already are, to assist with that contact tracing and exclude kids from school who are COVID positive until such investigation is completed or their quarantine period is finished. So here are the public health regions. You've probably all seen this map before of each of the OPH regions across our state. 3 contractors are in negotiations with the state right now for the testing part of this. 1 contractor for regions 2 and 4, a different contractor for regions 1, 3, and 9, and a 3rd contractor for regions 5, 6, 7, and 8. Most of the rural parts of the state and the north. So my ask here and recommendation is stay tuned and be ready to assist local schools in public health. A sad sort of piece of this, specifically for those of you here interested in research, is that these contractors are not allowed to use these specimens for research purposes, and that's I think is a missed opportunity. But the state was concerned that the possibility of using specimens for research would dissuade families from being willing to participate. It is what it is, but I think it's a sad missed opportunity. All right, so school-based vaccination programs. In our region, we began vaccinating in schools in April of this year, prior to the end of the school year. A really good uptake of vaccines in several high schools. 15 to 20% of 16 and 17-year-olds and a few 18-year-olds were vaccinated in the high schools where we've worked during late April and May, and so we've been very, very pleased with the uptake in the high school population. There is continued interest and vaccination occurring, through the summer at some of the schools where we're going back on a rotating basis and using those as community sites for vaccination. And our sort of headquarters of our vaccination team is open Monday through Friday from 10 to 6, and about a third of the individuals coming to get vaccinated at our headquarters north of the medical school are actually in that teenage population. Many of them before they go to camp, before they have summer travel in a month, other things like that in preparation. So we are seeing continued interest in the community for that. The state and Department of Health and Department of Education are putting together a big push in July and early August before school starts to really encourage kids who are vaccine eligible to get vaccinated before they go back to school. And the hope is that with particularly high school kids, that they're all eligible now based on their age, and the hope would be that 60, 70, 80% of some high schools would be vaccinated before the school begins in the fall. And it's going to take some work to accomplish that, but I think that's a reasonable goal, and it's more likely to happen than our nationwide goal of those numbers. And then once the school begins, it's likely there will be school-based vaccination programs. These are, by CDC standards, the most successful for influenza and seasonal vaccine like influenza, and we may couple COVID vaccination with influenza vaccination programs across the state. And the State Office of Public Health has contracts in place for school-based vaccination programs for both flu and COVID to be ready. So far, very few pediatric offices are vaccinating for COVID. And this is, I think, unfortunate, but I think it's partly because they're not seeing a great need at this point, not a lot of ask in their individual clinics, but CDC and LDH qualification is required in our area. Our center serves as a kind of a hub for vaccines, so that if a pediatric clinic needs vaccines available, even one dose or one vial, we can distribute that out to them with a courier so that they can vaccinate but not end up wasting a lot of vaccine. So a lot of creative things going into place there. What about younger kids, those less than age 12? Studies are underway. They'll use the immunobridging concept for an efficacy endpoint. That is, how does the antibody titer for this younger age groups compare to that of older age groups that we know have efficacy? And I've noted there for the 12 to 17-year-old age group, actually I should say the 12 to 15-year-old age group, antibody titers were about 2 to 3 times those of young adults. And so that's fairly reassuring that efficacy will follow with higher antibody titers. The Pfizer study, which we're a part of, and I'm the PI on our local Pfizer study in adults and kids, is already well underway. They finished their dose ranging part 1 study, and we have now fully enrolled the 5 to 11-year-old cohort. Started last Monday and finished this Tuesday. So in 7 business days, enrolled 2,200 subjects worldwide, basically 25 at each of the 84 sites worldwide. And the 6-month-old to 4-year-old cohort will be divided in 2, but that enrollment for that age range will begin this coming Monday. And Pfizer has already said publicly they expect to request EUA for ages 2 through 11 in September of this year. The Moderna study is also ongoing for pediatric vaccination down to 6 months of age. And the cohort age groups are listed there, about 2,000 subjects per each cohort, over 32 sites in the United States. J&J and Novavax have both said publicly they're planning those studies, but have not yet started, to my knowledge, and based on anything I could find today. An ongoing discussion is whether these vaccines should follow the EUA process or await full approval. And there are a lot of vaccine concerned parents who would prefer that full approval be given before they would consider vaccinating their child. The emergency youth authorization was adopted as an option after 9/11 to allow rapid deployment of medicines and biologics and the like based on known safety first, and accepting potentially less efficacy. And the full approval discussion and versus EUA for pediatric dosing is an important discussion, because as we've said, the goal of preventing death in the pediatric population is a stretch. There aren't that many deaths as opposed to the elderly population or older population over age 60, where the primary goal is prevent hospitalization and death, and the vaccines are very effective at that. You don't get those endpoints as you would. You don't get those endpoints with the pediatric population. And so we'll find that balance in these discussions. Politics involved, a lot of bureaucracy involved, as you all know. So a few notes before we finish. MISC, the multi-system inflammatory syndrome in children. The blue curve here follows the COVID-19 activity curve, and this is a post-infectious phenomenon that we've seen more than 24 cases up here in North Louisiana over the past year and a half. So far, CDC has confirmed over 4,000 cases that meet this definition. Of those, 36 deaths have occurred associated with MISC. And Louisiana is in this range of 100 to 149 cases statewide. You can see the data here by state. Race and ethnicity is an important factor here. We know that children of color are more likely to have MISC. Hispanic and African American, non-Hispanic account for about 30% each of the cases of MISC, followed by Caucasian kids in the 25-28% range. By age, this group is not our youngest, but sort of that school-age kids, 5 to 9 being the predominant proportion of infections, and then the 10 to 15-year-old age range following next. And this is a spectrum of disease. We see a lot that is mild, some moderate, and less in the severe category. Treatment is evolving. Hospitalized patients with MISC, if they have shock or multi-organ dysfunction, are recommended for both steroids and IVIG therapy. But if they're more stable, IVIG therapy alone is acceptable. And we're using some of our secondary drugs, anakinra, infliximab, and other tocilizumab and other modulators when necessary as second-line therapy. This data from France made it clear that the outcomes were clearly more favorable when IVIG and methylprednisolone were used in combination, especially for those kids with left ventricular dysfunction. Spectrum of disease gives us a spectrum of treatment modalities, and these are guidelines out of Columbia University Hospital in New York, and other big pediatric centers also have developed similar guidelines based on severity and treatment response over time. So what is going on here? Well, this is really seems to be a post-infectious inflammatory process. It's not directed by viral invasion. And those kids, in this graphic on the far right, with severe disease, including MISC, tend to have more of a chemokine predominance and IL-6 as opposed to an interferon response that is blunted or I guess reversed ratio of those responses compared to those kids with mild disease. The underlying factors involved here, whether they're viral in terms of blocking immune responses or genetic in terms of innate immune system differences that explain this pathogenesis, is currently under investigation, but not well known. Pathophysiology is also seems to be related to some dysregulation in the innate immune response. Most of the kids we've seen with MISC have had no known infection with COVID prior to getting sick. And some of these have been even severe cases. They come in with what looks like Kawasaki disease, a multi-system inflammatory syndrome. And the only clue we have that it's MISC really, other than the laboratory values that are so crazy out of whack, ferritins in the tens of thousands and the like, and D-dimers in the 25,000 range, is that their antibody to COVID-19 is positive. But they mostly have not known that they've had prior COVID infection. The hyperinflation or inflammation differs from that of Kawasaki disease. We don't see the coronary artery aneurysms of Kawasaki disease in MISC, but we do see more abdominal complaints and more neurologic complaints in the MISC group. And finally, a few notes on the pericarditis and myocarditis after COVID vaccination. CDC has confirmed over 225 cases and investigating many more, and about 800 reports now of myocarditis and pericarditis, mostly associated with the Pfizer vaccine, as you would expect, because that's what's been used in younger age populations. Most of these cases are in male adolescents and young adults age 16 and older, and mostly after the second dose of vaccine, occurring typically within a couple of days, 4 or 5 days or so of their COVID vaccination. And some of the data is summarized here. Of the 285 confirmed cases, first confirmed cases by CDC, 270 were discharged, vast majority to home, 81% have made full recovery, and a few others have ongoing symptoms. 15 at the point of this report in early June were still hospitalized, including 3 in intensive care. So again, a spectrum of disease. And what the ACIP will be considering this weekend is really summarized in the last 2 paragraphs, and they'll obviously have more data, but in this first group of 285, 79 cases of myocarditis reported in teens 16 or 17 after second dose. The expected number compared in historic was 2 to 19 cases. So you're talking about 35 cases per million doses, and somewhere around a 4 to 40% higher a number of cases more than expected based on prior data in the population for these syndromes. And 196 cases in young adults with an expectation of anywhere from 8 to 83. So again, 21 cases per million doses and somewhere around 2.5 to 24% more than expected. The recommendations are summarized here. I'll just let you go to CDC's website to look at sort of what is considered for the evaluation of patients who have this syndrome. But it's basically going to be looking for patients who have acute chest pain, shortness of breath, or palpitations, who are adolescents or young adults. This is not likely to be ischemic disease like you see in older adults. So in summary, we're approaching the halfway point in the pandemic from my perspective, but we got to keep our foot on the gas pedal. We know variants are emerging. Education is clearly important. We've got to remember belief eclipses science every time, much to our chagrin. You can't fight vaccine concerns only with the facts. And so working together, we can encourage vaccine and testing, liberally testing, and keep in touch with public health and your patients because we've got a long ways to go and they're looking for your assistance. So Mike, I turn it over to you.
Before we do, we can really don't have time for many questions, but if anybody has a question real quick, you're welcome to ask it.
Hey, John, this is Connie.
Connie who?
Your friend, Connie. I'm wondering what your thoughts on, or if you have any, because I know this is speculation. Do you see us in the next year or so getting to the point where, like with schools, that COVID vaccine would be mandated, or do you just see them always steering clear of that?
Right now, the political—
if you had to make a speculation.
Yeah, the political situation right now is way too divisive to even consider vaccine mandates, and I don't anticipate those happening for at least a few years. I mean, we can't even get to the point of agreeing on whether we should, businesses can require proof of COVID vaccination and COVID passports and all of those kind of things. So I think the politics is just too divisive right now.
Gotcha. Great
One
presentation.
quick thing, John, before we go, or before we move on, do you see any long hauler symptoms in any of the children?
We do. Some of the MISC kids have definitely fit that category. Other kids who've had acute COVID do have, some of them have residual, pulmonary impairment, asthma-like symptoms for several months afterward, can't return to full athletic participation because of fatigue. I don't think it's quite as common as adults, but we're really working to identify those kids as quickly as we can and get them into sort of reconditioning programs using physical therapy and a lot of emotional support to do it. And so, but we are seeing them. We definitely are.
Okay, well, thank you very much, Dr. Vanchiere. If anybody has any other questions, put them in the chat. He will probably be able to answer them through the chat mechanism. I'm going to move on now to Dr. Michael Hagensie. He's a native of Chicago and earned his MD and PhD from Baylor College of Medicine in Houston. He completed internal medicine residency and fellowship in infectious disease at the University of Washington, the affiliated hospitals in Seattle. From 1994 to 96, he was postdoctoral fellow at the Fred Hutch Center and instructor in the Division of Infectious Diseases at the University of Washington affiliated hospital. Joined the LSU Faculty School of Medicine in 1996 as an assistant professor in the section of infectious diseases. His laboratory studies the interaction of EBV and HPV in the development of cervical dysplasia and HIV, looking for ways to improve existing HIV serological assays and examining the role of interactions between EBV and HPV related cervical dysplasia in HIV negative women. With his vast serology background, he's also been quite interested in the antibody responses to SARS-CoV-2. And today he will present the work on the antibody response to SARS-CoV-2 and the COVID-19 vaccines. Go ahead, Mike.
Thanks, Paul. Can you hear me okay, Paul?
Yes.
Okay. And John, that was fantastic. I just wanted to reach out to you and say that. Okay. So this is kind of my laundry list of things we're going to briefly go over, and I won't go through this. I'll just go introduce it as I go from slide to slide. But the first thing is, now, how do we create an immunoassay? And why would I want to get involved in this? Well, how does one develop one? And then why should I, as Dr. Hagensee, who's an HPV person, try to dab into COVID research? Well, there's a number of papers that my colleagues and I, particularly in the Seattle training with Jody Carter, we developed Hpv serological assays, and we went from not having a positive or negative control to getting an assay that was reasonable, although it turns out this is not a particularly useful clinical test. But I do have a fair amount of background, and when kind of push came to shove a year ago, we decided to get started trying to see if we could generate some data. And the real goal of this was trying to define, we weren't trying to go into the hospitals and find the acute seroconversion, because there was a lot of dangers with that. We had PPE we had to be worried about, and we didn't want to waste it on this. But we're really more focusing on those that did acquire COVID. How long did their antibodies last, and are they felt to be protective? So we're using what's called an indirect ELISA. And what we do is we need an antigen, and we adhere it to a solid plate. Then we add their patient sera, which is the primary antibody. We then add an antibody to the human sera linked to an enzyme, and the enzyme generates a signal. So a relatively simple test. And there might be ways, probably was over 100 biotech companies that got into the COVID-19 antibody testing early on. And it may really confuse the field. And so we decided, we were thinking about making the antigens ourselves, but it turned out by the time we could gear up to do that, we could just buy it. So we ended up buying two proteins, the receptor binding domain, which is part of the spike protein. That's what interacts with the ACE2 inhibitor, is the binding of the COVID-19 to or SARS-CoV-2 to infectable cells. And then the other very interesting protein is this one in green, a nucleocapsid, which is more internal to the coronavirus. Now you can imagine the spike protein out here is very unique to each coronavirus. However, the nucleocapsid protein is more generic across many different coronaviruses. So we didn't start with anything. So how do we get started? We were able to get some discarded unidentified sera from UMC. We screened about 150, and we found about 10 or 20 to seem to react strongly, kind of this yellow color on this ELISA plate. Now we were fortunate to have negative controls in my freezers, and this is serum collected before 2015, and we made a pool of 20 sera. We started screening at a 1 to 100 dilution, and then those that were positive, we then started titering at 1 to 10, and then we defined a cut point as 3 standard deviations over the average of 3 negative control wells. So this is an example of some of the data we got early, and The red arrow here points to a positive, a serum sample that was clearly positive. That's easy to interpret. The blue arrow points to this serum sample, which was clearly negative, and that's easy to interpret. What's more difficult, and this is our cut point, the red line here, is this serum right here, which is kind of in between, and we call that indeterminate, and then we go ahead and we'll titer that. This is an example of the titer place that we have, and these are 3 clearly positive samples, and that's their serum titer there. And then this sample here, which was kind of weakly positive at a high dilution, but then quickly lost it. And this was felt to be actually seronegative. So a titer over 1 to 160, meaning we dilute the serum 160 times and still get a positive result, is felt to be positive. Less than 1 to 80 was felt to be negative. And if you hit right at 180, we couldn't really tell if it was positive or negative. Okay. So how are we doing this? How do we compare to other people in the world here? Well, in terms of confirmed positive, and these are people that had a SARS-CoV RNA test that was positive, about 88 out of 100 had RBD antibodies, and 90 out of 100 had N antibodies, and this defines their sensitivity. And for example, and this is a study from Emory, and they found a sensitivity between 75 and 100%, and the farther you got out from your day of diagnosis, the more likely you were to be positive. So I felt pretty good that we were at least in the right range. Well, how about specificity? Again, we tested a group of 134 storage sample, mostly from HIV positive people. These are from previous studies that I worked on. And for the RBD, again, the more specific protein, it was 93% specific. And for the N protein, as predicted, it was less specific, about 83%, likely cross-reaction to other coronaviruses. And again, this is pretty much in line that we see in other studies. This is one way to define specificity, but a better way to define specificity is something that I didn't simply have in my lab. And in this investigator group from the Netherlands, they had groups of serum samples from patients that had different coronavirus infections in the past that were stored, as well as flu, RSV, and some other things. And you can see here, only the patients that had COVID-19 reacted to the serological test, and all the patients with other infections did not react. And this is pretty powerful in terms of specificity for the COVID-19 pathogen. Another way to look at this that we could do, we just didn't have the finances to do it, is buy or make proteins from other coronaviruses and see if the COVID-19 patients cross-react. And this is a study, I believe these people were in New York State, and the only significant cross-reactivity in this situation is for SARS-CoV-1 in this study. These 2 blue only had 2 samples from that. But for MERS and other coronaviruses, they didn't see any significant cross-reactivity. Okay. All right. So now let's use our test. Let's go look at some patient populations and see how we did. So for confirmed positives, we already saw that data. But then we did have the opportunity to look at a few ICU patients that were very acutely ill from COVID-19, and all of them had antibodies to both RBD and the N protein. Healthcare workers that were not in the, obviously not in the ICU, in some cases they were not admitted at all to the hospital, had high rates of seropositivity, and others are other interested people who weren't healthcare workers. Then we had a group of people who were just healthcare workers but had no positive COVID test, and their rates of positivity were relatively low. For RBD, it was 17%. And then others are non-healthcare workers, just friends, family, whatever, who wanted to be tested, and their rates were relatively low as well. How does this 17% in healthcare workers compare? Well, this came out of the MMWR. This was in September of 2020, and various other healthcare systems across the nation. And Montefiore, which is in New York, which obviously had a huge outbreak, their rates are up to 30%. This red bars are 17%. And Beth Israel in Boston had high rates. But the other sites had lower rates, but none of them were like Seattle or other really prominent early infections in the game. So I think our 17% seemed reasonable. It also seemed reasonable for a study done at Ochsner here in New Orleans. And this is looking at healthcare workers in 75 people, and this is by zip code in terms of darker red and more seropositive. And they got an overall 15%, which I think fits nicely with our 17%. So I think we're on the right track here. And then breaking it down in terms of who actually had who were seropositive. Obviously, patients are more likely to be seropositive than non-patients. Age didn't seem to make a difference, or gender. Interestingly, we didn't have a lot of Hispanic or Latinos, but it had 86% of them were seropositive. It's kind of interesting, and in terms of John's data earlier, we're seeing higher rates in the Hispanic community. And then looking by race, African American also had high rates. What I'm circling here is basically our healthcare workers who took care of COVID patients at the job, they were not particularly a higher rate of seropositivity. And this and other data is that healthcare workers are really getting infected at home and not at work. And that was very encouraging that our protective gear actually seems to be functioning pretty well to prevent spread, at least in the hospital setting. Okay, the question that came up certainly early on is, what about point of care tests? So these are these little cassettes. You put a drop of blood in there, in a few minutes you get an answer. And this is one that I bought some in the lab. We actually didn't use a whole lot of them, and I'll show you why in a second. So this was from a patient that tested in the ELISA to be seronegative. This is the control bar, and here someplace would be a bar that would say you'd be seropositive. So this was a point of care test negative. On this side, this is the control bar again. This is from someone who was strongly positive in our assay. And if you look really closely, you see a really faint band there. So I would challenge the sensitivity of these point of care tests was less than desirable. And to confirm this, this is a study out of Europe, and they tested, I think, 8 or 9 point of care tests. And overall, at any point after infection, it was only about a 60% sensitive compared to the RNA test. If you waited longer period of time, 14, 28 days, it did get better. But in terms of a point of care test, you're probably you want those results earlier after exposure to know if you're going to be positive or not. And that's where the clinical decisions are. So basically, they don't work that great. And if they work at all, they work better later. And I know a number of these that had emergency use authorization, they've been pulled by the FDA because the data is just not supporting. And I certainly would not recommend anyone getting a point of care test at this point in time. Okay. So that's who's got antibodies. What about the quantity of antibodies using titers? And so I'm going to just really focus on our ICU patients and other patients, first the confirmed positives. And generally, the ICU patients had a pretty high titer, about 1 to 12,000. And that was about, we don't have a lot of numbers here, but about 2-fold higher than either a patient that may or may not have been admitted to the hospital or our healthcare workers that were found to be positive. And if we look at the literature, now people with more severe illness did have higher titers than those who had moderate or mild symptoms. And in here, these are people who were symptomatic versus asymptomatic in 2 other studies. So again, we're kind of seeing the same thing here, where the sicker you are, the more higher titer of antibodies that you can find. What about the function of the antibodies? Do they actually neutralize? And I have to, for this answer, and we don't have a complete answer yet, but I was fortunate to work with Dr. Alistair Ramsey in the Department of Microbiology and his graduate student, Jared Sheehan, who developed a pseudovariant assay. And what that does, it takes that RBD binding component, but puts it into a safer virus that can be more easily measured the infectivity, and it adds with or without antibody. And this is an example of some of the neutralization tests that Jared has done. And the interesting thing that we like to see in larger numbers is, I said the ICU patients have a higher titer of antibody, but when it comes to actually neutralization profiles, they may have a lower ability to actually be functional than those that out. Now we have very few here. We kind of have a group that's pretty strong in the RBD reactive than that. So we have a lot more to do. And they have a number more samples from our collective effort here to try to get a better idea of that. But that's certainly an interesting finding that we'd like to see if it can continue to pan out in larger numbers. And then this is not from our study yet because we don't have enough numbers, but generally the serum antibody titer tends to be similar to neutralization, at least in those patients that are not the ICU patients. So we don't necessarily have to go to the neutralization assay to get a better idea. I'm going to caveat that out that the ICU patients might be a little bit different breed because they're not doing well, obviously, with their COVID infection. And we may have to say, if you're not hospitalized in the ICU, that your titer might be able to glean some idea that will give you your level of protection. thing that's come out, at least in my infectious disease background, is can we use someone who's recovered from COVID, that plasma is convalescent plasma, to do what's called passive immunizations. And the idea here is that they're going to have antibodies that are neutralizing in the donated plasma, and they give it to a patient that has COVID, being ABO matched and things like that, and see if they were protected. And these slides come from our ID fellow, Dr. Nebelek, who was reviewed this just about a month ago. And probably for passive antibody therapy to be effective, you need to have a high titer on the donor sera, and you probably need to give this shortly after the onset of symptoms. Okay, so what do we know? So I'm going to very briefly go over this. So the older data, and this is older by 6 months ago compared to now, I'm just going to highlight no difference in mortality. 30-day mortality was similar. So even when you had high titers, they weren't necessarily giving it early, but we weren't seeing a lot of effect of convalescent plasma. And a lot of plasma programs, particularly like a university medical center, there wasn't a lot of enthusiasm to continue this. And so this kind of fell out of favor. I will say, to be fair, looking more recently in the last few months, there does seem to be a little bit of effect of improved outcome if you're given high titer plasma, but within 7 days of diagnosis. And these are not in patients that are intubated. So these are not super sick. And this is out of again, we're seeing about a 50-fold, a 2-fold drop in mortality. This other study was about a 3% drop in mortality. So if you have high titer donors and you give it early, it might be effective in some cases. All right, so our main question that we wanted to ask was, how long do these antibodies last? And we got to wait. We got to keep waiting. And we have a number of people who had COVID, and a lot of them are getting vaccinated or been vaccinated now, so we can't really look at natural history. So this might be, we'll have a few more time points in this natural history study, but this may go by the wayside. The thing that is concerning is, like for RBD, healthcare workers who are COVID, definitely have a COVID infection. 2/3 of them, so 10 out of 15, their titers are going down, and in some cases they're going down below detectable. The N protein seems to be a little bit more stable than the RBD protein, and there's good hope that there's immune memory, that if they get exposed again, that their titers would go back up. But this is concerning, at least from natural infection, and it may not be most likely what we know from other coronaviruses is not lifelong immunity. Okay. And again, you look at some studies, this was a 6-month time point, and then generally, the pink is early, the blue is later. Most people, their titers are going down. If they're asymptomatic or symptomatic, didn't seem to matter in terms of that. So again, even if you, the message here, even if you got infected with COVID, still get a vaccine. All right, so what about vaccines? Let's talk a little bit about that, and we'll kind of wind up my comments here. All right, so what does vaccination do to the antibody response? And we have more data than this. We just haven't had a chance to get it all worked out here. But so in the blue and in the red bars here is the titer against RBD. The white bars are titer against the N protein. Our vaccines so far to date are all against RBD. So we're seeing titers, on average titer, about 5,000–6,000, kind of what you saw for the routine patient who got COVID, not as high as the ICU patient. So kind of the moderate level of antibody titers, maybe a little bit higher than this. We got some additional testing. And then what's kind of interesting to me is, like, patient 8, 9, 10, they just got the vaccine and they most likely were not exposed to COVID and naturally, because they're not making antibodies against N. And then, for example, patient 15 and some of these others, they have a high titer against N and RBD, and they most likely have natural infection. And because we know these patients all got vaccinated, they also got vaccinated. We are starting to get a number of people who had natural infection plus vaccine, and we can see what vaccine does to those naturally infected compared to those that are not naturally infected. Are they functional? I have to defer to Dr. Ramsey's lab. He's very interested in this question too, and he's studying this as much as they possibly can. And like all of us, we all have our regular work to do and regular research projects to do, and this is an add-on. And so I know Jared's trying to finish up his PhD, And this is part of his PhD, but not the major part of it. And then we're just going to have to wait to see how long after vaccinations do antibodies last, and this follow people over time and see if their titers go down and what we want to know. What do we do about it? Our boosters in the future? We will see. Okay, so a really important question, which a lot of people are asking and we're starting to look at. What about our variants? Are we going to be protected against variants? And so this is my thanks to Ashley Winters, who's a PhD student in my colleague Dr. Cameron's lab, who she volunteered or we kind of coerced her to try to take on this to learn some ELISAs. And we don't have all the data cranked here yet, but it's really kind of interesting. So these are naturally infected people. And this is the titer to the UK variant in this kind of brown color compared to the wild type in the green. So the titer to the UK variant in a naturally infected serum sample, okay, is significantly lower. And this is another patient sample, the one that reduced, the titer was reduced in the UK variant, which could make them possibly susceptible to the UK variant. Okay, so not too many labs have focused on this because they're all focused on what about the vaccines. But this is interesting in our population. It's only about a third to 40% vaccinated. There's still a lot of people out there. So what do we know about people who are vaccinated? And so this is the titers for 3 people against the wild type, and this is for 3 people against the UK variant. And if you look, all the titers to the UK variant are at or higher, and I actually merged it down here and just overlapped these 2 graphs. And basically your titer was as good, if not better, against the UK variant. And this has been studied a lot more, and so at least the UK and the South Africa and the Brazil, those that I've seen, the current vaccines seem to be able to generate good high titer antibodies against them. I'm not up to date on what's going on in India, so I don't know about those variants, and obviously there may be new variants coming out. And so this will be obviously a ongoing problem, ongoing concern that needs to be continually looked at and tested. So the good news about variants is those vaccinated against COVID-19 have high titer antibodies against the UK variant and most likely other variants that are out there. The bad news, and maybe the message to people in Louisiana, even those you might have been naturally infected with COVID-19, you have lower titers against the UK variant, and you might be able to get reinfected by the UK variant. And there has been a big UK variant outbreak in the Lake Charles area. So it is in our states, and then it's in the New Orleans area as well. And so my kind of final message, which is a kind of a very consistent message, is everyone who's not vaccinated at this point needs to get vaccinated. And so I'll on there, I just want to say thanks to everybody in the labs that did everything. Amber, you've been amazing getting all these serum samples, and many thanks for everybody else helping out on this. And I'll stop there and we have time for questions if we can.
Thanks, Mike. Appreciate it. I know we're a little bit over time, but if anybody has a question, please put it in the chat or come off. Sam Landry is asking, any long COVID cases? Anybody any different, steady, high?
Yeah, we haven't seen a lot of that yet. And no, we're certainly in the adult looking at maybe getting a long hauler clinic going to look at that aspect. And then there's been some, patients that have had long-term RNA detection. And we don't have any of those in our cohort right now, but they would be interesting to look at in terms of that. And it's, these are one of those things, we kind of got started a little bit late in the game, but longitudinal questions, no one knows because it just hasn't enough time yet. And it'll be interesting to see. In terms of the vaccines, now all the vaccines are based against RBD, and there are some that were developed against N, and N may actually prevent you from all coronaviruses potentially. And so there may be future vaccines down the road to actually be more efficacious than the current ones we have and more long lasting. So it'll be interesting to see how this continues to evolve over time. And yeah, no, the N antibody is not boosted by vaccine, as you would predict, and because the vaccines right now all are RBD vaccines.
Other questions? I have one for you, Mike. I'm very intrigued by the ICU high titers and low neutralization type antibody. Are those mainly older people?
Yeah, and again, my hat's off to Amber. She's an amazing clinical coordinator because she's calling family members, asking for a tube of blood of someone. In many cases, they die the next day. So these are people who are succumbing to COVID-19. But I mean, one theory has been obviously the overreactive immune response, and is antibody part of that process? And we're trying to do some work with my summer student this summer to see if we can kind of look at complement fixation and things like that to see if these people in the ICU are having more complement activation, which may lead to some of their pathology. So we're still trying to hack through that and try to get these assays going.
I wonder too, whether those people who have recovered and getting then vaccinated, would they be potentially not able to produce the neutralizing part to the vaccine, or is that something completely different?
I think it's not out of the range of possibility, and that's where the functional assays are very interesting to go hand in hand. And I think both Dr. Ramsey and the team here would love to have we tried to get some outside funding, to really do this in more detail. And again, we're all in our kind of spare time trying to get these assays done because they're really interesting questions. And even though other places are looking at them, they're still interesting. We have unique populations here in the New Orleans area. They may things may behave differently here, so I think they're really important questions. But you bring up good points, Paul. We'll have to wait and see in terms of that. I know Dr. Ramsey and Jared, they've got I think they picked up 60 or 70 sero samples from us, so they have a lot more data coming down. And it would be interesting to see if we can delineate differences between the ICU patient and the non-ICU patient.
Okay, any other questions? I know we're a little bit over here, but this